Um, Purpose of this class is to highlight the sepsis concept, talk about hemodynamic shock, and also understand, people's roles in the project that we have in Memorial Hospital. Let's see.
That should. I think it's on.
There it is. Okay. All right. Now, before we talk about sepsis in general, I'm going to go over some of the basic science stuff. And sepsis, as you understand, is nothing but inflammation related to infection. Okay, so that's the key point, is inflammation related to infection. Now, if you look at the inflammatory cascade, and don't need to worry about the complexity of the slide, but the inflammatory cascade basically is a pretty complex process, and it happens in all cells of human body. All human body cells are capable of, initiating the inflammatory response. And this is just an example of what that might look like. And this is the area.
I think that should be turned on.
Yeah.
Hmm.
Well,
There, that's turning the page, but
yeah, okay, no, that's fine. Up top, you see that there's that's the cell membrane of human body, and that cell membrane is capable of leading to metabolism into free arachidonic acid, and that can be further degraded into or catalyzed into other different molecules like cyclooxygenase pathway and lipoxygenase pathway. And that can lead to many more subsequent chemicals called prostaglandins or interleukins and those kind of things. And those molecules, each can cause a lot of physiologic functions and dysfunctions in a human body. I kind of just mentioned them as evil humors that circulate in the body when there is an inflammation. And there are many of those. Some of the examples that I highlighted, and some of those molecules can do, and what those molecules can do, like the prostaglandin F2, D2, E2, and the leukotrienes. If you look at the functions of those, can cause vasodilatation, they can cause bronchoconstriction, cause myocardial dysfunction, etc., etc. So this slide highlights the numerous pathological derangements that these molecules can cause, and this is because of the inflammatory cascade. Now, some more chemicals to highlight, particularly the ones with interest is interleukin-1 and a tumor necrosis factor. These molecules can also cause similar issues. Some of them I highlighted there: hypertension, fever, recruitment of other cells. They cause endothelial permeability increase. What that means is like blood vessels get really leaky when there is inflammation, and they can leak fluid out of the blood vessels. They can also activate coagulation pathway and fibrinolytic pathway at the same time, meaning they can either cause hypercoagulable state or can cause thrombosis at the same time. Now, the whole purpose of inflammation, the way nature has made it, is to phagocytose the bad stuff that's going on, and then to repair and heal the injury that an organism or a cell or a human body sustains. Okay. However, this is a diagrammatic presentation of the same thing that I mentioned. If you have an inflammation up top, the macrophage is only one of the cells that can get excited and start spitting out stuff in there. On this side here, tumor necrosis factor, interleukin-1, interleukin-6, platelet activating factor, nitric oxide, etc. So those are the ones that I mentioned, and I understand, and you can understand them as being evil humors that circulate. They lead to endothelial damage. the same insult to a human body can lead to activation of coagulation cascade, recruitment of cells like neutrophils and stuff like that, and they all can lead to platelet dysfunction, metabolism of arachidonic acid, like I mentioned, and they all can lead to endothelial damage, tissue injury, or organ dysfunction. Okay. Now this is the potent, the bad side of inflammation. However, inflammation is essential because that's what we use to fight disease and to fight any kind of infection and those kind of things. Now again, to highlight, I'm not talking about infection per se, I'm talking about inflammation. And this whole thing is called inflammation. If the inflammation happens because of infection, then it's called sepsis. Okay, we're going to go into more detail of that later. And this is a diagram to show you that it can go both ways. If the inflammation is checked, and that happens as soon as inflammation starts, the body also has a counter-inflammatory mechanism called anti-inflammatory mechanism. That is just to make sure that the reaction that ensues is checked so that it doesn't overflow and go out of control. But what happens to the body after inflammation or any kind of insult, injury, depends on to which side of the inflammation wins. If the inflammation gets overwhelmingly more, then it might lead to cellular injury and multi-organ dysfunction instead of healing up. However, if it is checked, then it can lead to cellular repair and then recovery finally.
I'm so sorry about that.
Okay. Now, this is just to highlight the same thing I said again. Endothelial injury, I just wanted to mention that because endothelium or the blood vessel bed is where the most of the reactions are taking place. It can happen in any space, interstitial space, cell membrane, inside the cells, but mostly it's happening in the endothelial surface. So that's like where the war zone is, and it leads to, when the endothelium gets injury, or there is problem in the endothelium, what will happen next is there's a loss of autoregulation in many organ systems. Okay, so selectively speaking, much of the organ systems control their own blood flow, control their own energy source, and those kind of things. And that is called autoregulation, meaning whatever is happening throughout the body, a little bit of control is done at an organ level. And so that's called autoregulation. When that autoregulation gets messed up, you get a lot of microcirculatory balance, meaning either there is more blood supply or no blood supply as compared to controlled blood supply, and that can lead to thrombus formation and ultimately leads to injury to the mitochondria. Mitochondria is what you call the powerhouse of the cells. That's where the oxygen is ultimately utilized and energy is ultimately produced. When that happens, then there is energy crisis, leads to cell death. Okay, so this is just for you to kind of understand the extent of the process that happens at a tissue level and then at a cellular level, and that's all inflammation. Now, when there is inflammation or when there is overpouring of inflammation, then it can lead to a lot of tissue injury, as we discussed, as opposed to cellular healing and repair. Now, when that happens, when the inflammation overflows, some of the organ systems that get usually affected are highlighted here. Now, respiratory system, the lungs get affected quite a bit, regardless of what happens to a body. It's because the lung has a lot of blood supply. And so when the whole cardiac output goes into the lungs, because of the leaky vessels and stuff, most of the cells can get trapped in there, and they continue to create the reaction, leading to lung injury, usually manifested by hypoxia. It can affect the cardiovascular system also, so they can damage the myocardium, not causing heart attack, but damaging the myocardium by the inflammation, by the evil humors and the cells. And when you check their blood, it looks like they are having a heart attack because the troponins are elevated, it can cause myocardial dysfunction. So although you had a normal heart before, you had big inflammation, now you can't pump anymore. Although your coronary arteries could be perfectly normal. So that's that's manifested by hypotension, arrhythmias, etc. Kidneys are particularly sensitive to hypoxia because of their anatomic build. They have, when the glomeruli narrow down in one area, that area is called papilla. That's where most of the concentration occurs, where the kidneys kind of concentrate the water and the electrolyte. That area is very hypoxic to begin with. And whenever there's a little insult, that area gets insulted, and that area can get necrosis, what we call acute tubular necrosis. And usually people have no urine output, creatinine start to go up, that kind of stuff. Okay. Now, liver, for the same reason, it can get injured, and it doesn't clear drugs, metabolites, ammonia, and people can get, and the bilirubin could go up, stuff like that in the liver. And it can also affect the bone marrow, cause platelet damage, cause hemoglobin production to shut off, that kind of stuff. So the whole point being, no organ system is immune to unchecked inflammation. Okay, now that's the whole diagram was about multi-organ dysfunction or multi-organ failure, and the mechanism, some of the mechanisms I highlighted here include the lung, the endothelial leak again. So the endothelium is where the happening place is, and when it leaks a lot of fluid, it leaks a lot of cells, and it looks like you got a pneumonia, although you may not have pneumonia, but this is just inflammation, what we call pneumonitis. Okay, that's in the lungs. Heart, the same thing, we talked about that. Liver, kidneys, and nervous system is particularly true in elderly people. It is like I described the energy crisis, loss of autoregulation. There's a lot of nitric oxide that forms because the endothelium is messed up. When that happens, the blood vessels dilate, and the mitochondrial dysfunction occurs, and you can't utilize energy. So people generally get kind of obtunded, get comatose, just because they have something else going on, like a UTI. That's called encephalopathy. Happens usually in the elderly. Now, coming back to the sepsis project, why is it being hammered everywhere throughout the country? The point being, it's very common, and the mortality could be really high. And when you talk about 50% mortality, that's considered a lot in medicine. We talk about 1%, 2%, 5%, that kind of stuff. 50% is a lot. 1 or 2 people dead. That's a lot. And depending on what phase of sepsis you encounter somebody at. And then there's also something that can be done about it. So it's a good thing to talk about that. If there was nothing to be done, well, there's really no point. But there's something that could be done about it. So that's why sepsis is gaining a lot of attention. This was going on for a long time. This is a multi-national project where a lot of people in Europe, South Africa, Australia, United States, they got together and came up with this plan of surviving sepsis campaign. That was in 2002. So a lot of hospitals got enrolled in this project, and the point was to kind of conduct research, come up with good ideas, come up with guidelines, education, awareness, so on and so forth. Okay, so it's been going on a long time. We started now because the problem being, the reason being, now it is mandated. Okay, now CMS mandates that hospitals like us, we come up with some sort of a project and demonstrate that we have implemented that project and demonstrate that we made some difference in people's lives to be able to get paid. So when Uncle Sam mandates it, there's no way around it. So that's why we're doing it. Also, it turns out that our hospital data is a little worse than other places. So a lot of people are dying. 23% mortality on folks that we have sent to University of Utah. Now, statistics, you understand, is statistics, but I just threw it out there just for the sake of it. Okay. Now, somebody said there are lies, the more lies, and there's statistics. Okay, you can tweak that number however you like it. However, I mean, that's a raw data, and I just thought, it's impressive. And this is also an opportunity to educate and save lives. Now, this slide is just it was given to us in one of the sepsis meetings. For those of you who don't know, there's a sepsis committee. There's a lot of people in there, lab and nursing, and doctors, administration, of course, and so on and so forth. So this was presented to us. The point of this slide is not for you to memorize, but just to let you know that the areas of patient care down there, ED, ICU, med-surg, everywhere, the sepsis is present, and there is issues with sepsis. So, meaning no area is immune to the problem, and it requires everybody's effort. So that's the point of this slide. Now, coffee break. By the way, feel free to ask me any questions, okay, in the meantime. Now, what I described so far is kind of vague science, what we call the basic science part of it. So it's confusing, could be confusing, and we need some specific numbers, definitions, and we're going to go over some of that stuff. Okay, so far, I think to summarize the previous slides, all I would remember is sepsis is inflammation because of infection, and inflammation is it could be a bad deal, although it's essential. If it gets out of control, it could be bad in the sense it can affect all organ systems and damage tissue. Okay, so that's what we pretty much discussed. And their weapons, the inflammation's weapon is cells and these evil humors, prostaglandins, interleukins, so on and so forth. Okay, so that's how it is. Now, defining sepsis, if you understood what we discussed, how it affects all cells, you can understand that most organ system would be affected. Now, SIRS stands for Systemic Inflammatory Response Syndrome. What that means is the inflammation has gotten out of a local area or a tissue system, and it has overflown to affect the organism or the human being systemically. So that's why the word systemic inflammatory response syndrome. So to give you an example, if you get punched on your face could be swollen, and you could hurt in the face. By the way, the 4 or 5 cardinal signs of inflammation include rubor, means red, because there's a lot of blood vessels, as you saw. It increases blood vessels. And calor is heat, because there's too many cells coming in there and a lot of reaction going on there. Dolor means pain. Pain is too, kind of protective mechanism. Rubor, calor, dolor, tumors are now, you got a little swelling because the vessels, when they get there, they get really leaky, so you got a lot of that swelling. And the last one is functional lacia, meaning you lose function of that area, it hurts, can't move it. Okay, so those are 5 signs of inflammation. So that's local, it's just local, but when it gets out of that area and it starts to affect you systemically, then it's called systemic inflammatory response syndrome. Okay, now some of the signs could be temperature, elevation or drop, 38.3 or less than 36, heart rate more than 90, respiratory rate more than 20, altered mental status. Now you understand why that happens.
Cardiopulmonary, please call 8372. Cardiopulmonary, please call 8372.
And now the positive fluid balance, it could happen. It's not commonly measured, but it's possible. The reason that happens is because of stress hormones that kick in when you have inflammation. Those stress hormones tend to hold on to water. Hyperglycemia for the same reason, because then they tend to make a lot of glucose, the stress hormones. Now, if you check somebody's labs at that time, you can obviously see leukocytosis, right? Or it's so stunned that it can't really produce any cells, so or either leukopenia or leukocytosis, extremes of those. They have a lot of immature cells coming out of the marrow, and that's called bands, bandemia. Now, the C-reactive protein, it could be up, and plasma procalcitonin if there's a bacterial infection. So these are some chemicals which we call an active reactants. So whenever there's something active going on, these could get elevated. So these are some of the things that you will see on anybody with SIRS. Now, if somebody has SIRS because of infection, then that's sepsis. Okay, so SIRS, it can happen because you have a trauma, or because you have, your tooth got pulled, or you got in a car accident, you could be in SIRS. But if you have infection, then it's called sepsis. Now, that was the criteria for sepsis there, or some of those things that you'd see in sepsis. When you have severe sepsis, it gets a little worse, then the mortality could go up, from about 10-15% to 20 to 35%. And then the severe sepsis basically means sepsis plus end organ damage. Now, end organs, if you remember that slide, which organ systems could be affected and why, that's why. So that's what it is. And basically the criteria that is listed here include the same thing. The lactate above normal limit because the liver can't process it. Urine output low for obvious reasons we talked about. Lung injury, and if you do a blood gas, their hypoxia level is pretty high. And the creatinine going up because the kidneys are damaged. Bilirubin going up because of the liver. Platelet because of the bone marrow, and coagulopathy for the same reason. So basically, on the slide, what I showed you, some of the common organ systems that could be involved because of overflow and inflammation. These are all the listed parameters that define those situations. Okay. Now there's something called sepsis-induced hypotension up front, which I didn't mention so far. Now before they get into shock, you could see a little bit of hypotension to begin with. And that hypotension is defined as systolic blood pressure less than 90. If somebody is hypertensive, you could still be normal by our numbers, but for that particular person, that value could be hypotension. Let's say if somebody runs at 160 all the time, and their systolic blood pressure is 100, now they don't meet that criteria, less than 90, but it is hypotension for them. So the other way to define that is systolic blood pressure more than 40 from their original number. Or, by all means, for that age, if there is more than 2 standard deviation, again, statistics, you know how to calculate 2 standard deviation? I don't, but I got to say that because it's there. Anyway, so the numbers that for us to remember is less than 90 or more than 40 from their original systolic. Okay. Now septic shock, when it gets to the extreme, when you have seen that hypotension, you give them a little fluid, still they don't respond, that's septic shock. So it is, the mortality is 40 to 60%, persistent hypotension and organ damage despite you trying to intervene in between. Okay, so that's that. Now talking about shock, any questions so far? So talking about shock, there's certain concepts that we gotta understand so that we understand why we do fluids, why we measure this, why we measure that, those kind of things. Okay, so this is a little bit of detail on what happens in shock. Now, shock deals with circulatory system. Circulatory system includes the heart, which pumps, arteries which take the blood out of the heart, venous system that brings blood back to the heart. Okay, so now these areas, they have specific functions, and those functions and physiology could be understood by these different terms: preload, afterload, and contractility. Okay. Now talking about preload, what preload means is it is the volume in the heart before it pumps blood. Okay, so before it pumps, meaning it's in diastole. So let's say the heart starts to expand, okay, the blood is filling, and then it pumps. Okay, blood is filling, it pumps. So when the blood is all filled, ready to pump, what that is, that phase is called end diastole. End diastolic volume is preload. Okay, so that's how much you got, how much blood you got to pump. And that can be looked at as end diastolic volume, or it could also be looked at as an end diastolic pressure. Okay, how much pressure builds up as blood fills, that's preload. Okay, it could also be looked at like an end diastolic muscle stretch of the myocardium. Okay, so that's basically preload. And now the preload is a function of venous system. Okay, because as you understood, the veins are the ones that carry the blood back to the heart. So what's going on in the venous system determines preload. Okay, so for example, and what happens in the venous system is a function of volume. Okay, so if you lose volume, if you're hypovolemic, you lost blood, or you had diarrhea, you haven't eaten or drank, you're in the desert, whatever that might be. If you have no good volume in your system, then there's not much blood coming in, so the preload is less. Okay, so it's a matter of volume. The other concept also to understand is the venous or the arterial system in human body is controlled by sympathetic activity, parasympathetic activity, etc. So they have a particular tone to the blood vessels at any given time. So it is also, now if the sympathetic tone is increased, the venous system can squeeze and pump more blood back into the heart. So if the sympathetic system is not working, it can get flabby, and although it's full, it may not bring back much blood into the heart. So it's a function of how much volume you got to begin with and how much tone you got. So preload is a function of that. Okay. Now it's important to understand that venous.
IT, please call 8507. IT, please call 8507.
So the venous system carries a lot of. It's a big pool of blood. Okay, it is also a reservoir of blood. So in the calves and in other areas, they have a big pool of blood, and for that reason, the calf muscle or the soleus muscle used to be called the second heart. You know, probably Charlene remembers, right? They used to teach that, no? Anyway, so we well, that's what they said. It's like there's so much blood there that it can squeeze like the heart does. So it's called the peripheral heart. So what I mean to say is there's a lot of reserved blood in the circulation that kind of just sits there otherwise. And that blood can be pumped at any time if needed based on the sympathetic tone of the nervous system. Okay, so that's preload. Now afterload is the resistance to the flow. So now the heart pumped blood, but what does it have to pump against is afterload. So let's say hypertension, somebody is very hypertensive, the arterial tone is elevated. So the afterload is elevated. Okay, somebody who's got a nervous system problem or sympathetic system problem, then the load could be, the arterial tone could be lost, and that way the afterload is decreased. So the afterload is a function of the tone of the arterial system. Okay, so that's that. Contractility is a function of the myocardium itself, the heart itself. Contractility, what that means is the force of contraction of the myocardium. Okay, so it is how, with what force can it generate to pump blood is called contractility. Now the things that affect contractility include the health of the muscle itself, because if you get cardiomyopathy, muscle is unhealthy, it really can't produce a lot of pressure when contracting. So that's one. The other one is a sympathetic activity to the heart. So the sympathetic activity can increase the force of contraction. You know, so that's contractility. Okay, so if people have, and the sympathetic activity depends on hormones and so on and so forth. So you know, it is affected by different things. But contractility, for you to understand, is a function of the myocardial muscle. Okay. Should I tell them that joke? So there's a joke, you know, just for you to understand the contractility is how fast one can do. How fast can it produce the pressure? Okay, what is the how fast? How strongly can it contract? An example is you're at a red light, and when the red light turns green, you go, right? It's a pickup of, you know, whatever car you drive. So if you got a Beamer or a Ferrari like one of our dogs do, then you know you're way 100 meters ahead. It's contractility, you know. It's not that these cars can't get to there. You can't get there, and they can also drive 100 miles an hour, but he could get, you know, way ahead. So that's contractility in a way, you know. So there was a husband and wife, right? And the title of the joke is how the fight started. Okay. So the wife said, it was her birthday was coming, I guess, and she said, "Honey, can you get me something shiny and that goes from 0 to 60 in 3 seconds?" And you and the husband said, sure, I'll get you that, and he bought her a weighing machine. So that's how the fight started. So that's contractility. Okay? Now, the Frank-Starling law is very common in hemodynamics. What it is this kind of gives you an idea of preload and contractility, cardiac output, that kind of stuff. Okay, what it is on the horizontal one is left ventricular end diastolic pressure. So that's pretty much preload. So that what that means is that could be looked at as a length of the muscle fiber, or the pressure that is in there before it pumps blood. So at any given pressure, let's see. I'll try this again. Something alright with this thing. I think the battery is low. Anyway,
It could be.
so what that is this was originally done in a muscle fiber. Okay, so that's how it is defined here. That is stroke volume or cardiac output. Stroke volume is how much blood is pumped out. Okay, now as you lengthen the muscle, the higher the stroke volume. What that means is it's like a rubber band. You stretch it more, it snaps back faster. Snaps back harder. Stretches even more, snaps back with more force. Okay, so the more the preload, the higher the stroke volume. And you increase the preload, giving more fluid, higher the stroke volume. But the Frank-Starling law also is that at one point, it kind of gets to where it kind of plateaus. So you stretch it too much, then it can't pump. Okay, so originally the Frank-Starling law is going to come down like that. So as you stretch the muscle, more cardiac output, stretch the muscle, more cardiac output, but at some point it's going to fail. Okay, now that's for a normal heart. The first line is for the normal heart, and if you look at the curve, it's very steep. Here, if you look, for that muscle, the cardiac output is here. Okay, if you stretch that muscle further, cardiac output goes way up. Okay, but for a diseased muscle, for the same amount of length, the cardiac output is much lower, and as you stretch, it really doesn't kind of generate much, because the slope is not as steep, meaning it doesn't increase the cardiac output as much as you increase it. For more diseased heart, it's even worse. No matter how much you increase that, there's really no change in cardiac output. Okay, so this is a preload if you look at it that way. It's a preload, and increasing preload works to a certain extent. After a while, it snaps. So that's how it is. Okay, for a normal heart, increasing preload usually leads to a lot of cardiac output increase. So that's Frank-Starling's law. That's preload and cardiac output. Okay. In other words, you can also understand it by saying, as you increase the preload, the contractility increases. More preload, more contractility, but then at one point it's going to snap. Okay. Now, several definitions that we got to go through. This is important for NICOM measurement, and try to correlate this with the concept of preload, afterload, contractility, etc. Okay. Now, stroke volume it basically means how much blood is pumped out in one contraction. Okay, so when the heart beats, how much blood is pumped out? That's stroke volume. It's very simple, and we're talking about left ventricle, by the way. Okay, so usually the stroke volume is about 55 to 100 ml, depending upon who's who. Okay, small versus big person. The next one is a stroke volume index. What that means is it's how much blood is pumped relative to the body surface area of that person. Okay, it gives you a more accurate picture of what that stroke volume means to that particular person. Okay, so imagine I'm small, and I could have 50 cc's of stroke volume, and that could be plenty for me. But if you take that as normal, and if there's a big guy, he's got 50 cc stroke volume, and he might be in shock. Right? But for you, when you look at it, 50 normal, not really, because it depends on what he needs. Bigger person will need bigger stroke volume to cover their area, and this is stroke volume divided by body surface area. That's called stroke volume index. Okay, that might be a more accurate assessment at extremes of weight or how big somebody is. Now MAP, everybody knows that. MAP is considered to be an important number to define tissue perfusion. Everybody believes that above 65, most of the tissues are well perfused. Okay? Cardiac output is how much stroke volume in 1 minute. Okay, so stroke volume times heart rate gives you cardiac output. So it's a minute function of stroke volume. Cardiac index is again the same thing like stroke volume index, and it is cardiac output relative to the person's body surface area. Again, it gives you a better picture of whether that cardiac output, wherever that lies in your normal values, whether that's adequate for that person or not. Okay, so these are important numbers. Total peripheral resistance. This is a concept where I mentioned before about that sympathetic tone of the blood vessels. Okay, so peripheral resistance means resistance of all blood vessels combined. Okay, and I don't know how they come up with that number, but that's how it is. It's 900 to 1300 dynes per second per centimeter to the power of -5. Okay, and that's in your NICOM. In the NICOM, I think it says, does it say TPR? I think it says TPR, yeah.
TPR,
so,
TPRI.
yeah, so TPR. And TPRI basically is total peripheral resistance to body surface area. Okay, so that's how it is. Now that's if you think about it, TPR could be a function of afterload. Cardiac output is a function of contractility and preload. Stroke volume is a function of contractility and preload. Okay? Now TPR is also called systemic vascular resistance, and I will talk about that in a second. Now stroke volume variation, that's a number that's in the NICOM. This is a little weird number because if you look at the definition of it, it is variation in stroke volume over a period of time. Okay, so how much stroke volume gets out of the heart on an average in about 30 seconds is what it is. Okay, so stroke volume variability, I scratched that. Now what I'm saying is stroke volume variation is how much does the stroke volume vary in a given time frame, and the time frame usually is 30 seconds. So highest stroke volume minus lowest stroke volume divided by average stroke volume, and this is defined as a percentage. What that means is it just means but one more concept to clear at this point is the stroke volume and the preload is affected by breathing. Okay, so what happens is when you inspire, the thoracic pressure is negative. When the thoracic pressure is negative, there's a lot of blood that can flow in because of less resistance. So the preload increases when you inspirate, and then there's a lot of blood coming in. The stroke volume increases. Okay, when you expire, the chest pressure is a positive pressure. There's less preload, and that leads to less cardiac output or less stroke volume. Okay, so during inspiration and expiration, normally speaking, it may vary by little. So in normal person, it really doesn't make a difference whether you're breathing in or breathing out. However, if you are volume depleted, then a little bit of change of pressure could make a lot of difference. Meaning, if you have bled, then your pressures can swing just because of that little pressure difference between inspiration and expiration. That's where this volume variation comes into play, because if you're volume depleted and you're breathing, your stroke volume could be high, then all of a sudden it could be significantly different if you're volume depleted. And that's where this comes in, is a stroke volume variation. If you have a lot of stroke volume variation during breathing, then that means that maybe you're volume depleted. Okay, so that's where it's going. Now pulse pressure is just a difference of systolic pressure minus diastolic pressure. I'll talk about that in a little bit here. Now, just to define shock, and to define shock and to understand what type of shock, you got to understand those three things: preload, afterload, contractility, stroke volume, cardiac output, total peripheral resistance. Those are very important in defining and understanding what type of shock we're dealing with. Okay. Now there are 4 types of shock: hypovolemic shock, distributive shock, chirogenic shock, and obstructive shock. The one that we're going to concentrate on is the distributive shock, which is, the sepsis is one of the main causes of that shock. Now, hypovolemic shock is fairly easy to understand. You lose volume, you get less preload, hence less stroke volume. hence no blood pressure, hence in the gurney, okay, by the morgue. Now, now distributive shock, the concept is a little weird because remember that sympathetic tone I talked about? So what happens is when you have sepsis or when you have adrenal crisis or neurogenic shock, like the spine is gone, the sympathetic tone beyond that is messed up. So all the blood vessels, instead of kind of toning up, they get flabby. And then they get kind of, because of inflammation, if you understand, they get kind of leaky. So all the blood is pooled and the fluid is kind of seeping out. So it's kind of distributed everywhere. And so what happens is, although you may have plenty of volume, you're not getting any preload. And hence, you're not getting any stroke volume. And that's called distributive shock. Okay, so it has to do with the tone, it has to do with the capillary leak, and it has to do with vasodilatation. Now, normally speaking, the normal response of human body is anytime there is hypoperfusion, let's say your blood pressure goes low, or you lose volume, and you decrease stroke volume so that the perfusion pressure is low, as soon as that happens, all organ systems, including all the peripheral vessels, they actually contract, they clamp down. That's why when somebody kind of gets a cardiogenic or gets a vasovagal attack or something, they're kind of cold and clammy because all the blood vessels are kind of clamped down. The reason for clamping down is to increase the pressure so that the perfusion pressure remains. Okay, so that's the body's mechanism to continue to squeeze blood into the organ system by increasing the pressure when the volume gets compromised. Now that's normal response to any kind of shock. So most of the time you see that these vessels are clamped down whenever there is low perfusion. However, distributive shock is the opposite. So the peripheral resistance is low in distributive shock. In any other shock, the peripheral resistance is high. Okay, do you understand? Now, hypervolemic distributive cardiogenic shock, it's very easy to understand. Basically, the heart is not pumping, so you got less stroke volume. And then, since the heart is not pumping, all the fluid is backlogged. You get a lot of pressure built up, edema. That's cardiogenic shock. Obstructive shock, it's like all the systems could be working, but there is obstruction to the flow. For example, you get a massive pulmonary embolism. The heart is trying to pump, but there's no way to go. So that's a shock situation because there's obstruction in the pathway. The other common one, or the other dreaded one, is a tension pneumothorax. So there's so much pressure in the thorax that there's no preload coming in, and so it's obstructive shock. Okay, the other one is cardiac tamponade. When the heart got fluid all around it, causing a lot of pressure, the heart really can't open up to fill, and that's obstructive shock because there's obstruction to the flow. Okay, so you're not going to see, you might see all of these in depending on where you're at, but the one that we're going to concentrate on is the septic shock. Now this is just like just to clarify and to understand that one step further is I have listed some of the types of shock and what happens to the measurements that we're going to do. Okay, and that's important. Same thing you're going to do in NICOM. So let's say SVR is TPR for your purpose, cardiac output, and CVP. Okay, now CVP, you understand, is a function of preload too, right? Because that's a venous system. Venous system drains blood into the heart. So CVP is a function of how much fluid you got or how much blood you have. It's basically preload. Okay, so imagine distributive shock. What will happen to the total peripheral resistance, or SVR? It's low, right? What happens to CVP? Because the blood is all pooled, usually it is low. It could be normal, but it's low. Cardiac output, usually the cardiac output would remain the same. However, if you have no blood, all distributed, then the cardiac output could be low. Okay, so when you measure the NICOM, the thing to look for is the total peripheral resistance will be low, cardiac output will be variable, CVP will probably be low, and stroke volume for the same issue. Cardiac output, stroke volume, they all kind of are similar concepts. So if one is low, the other one should be low. Now, hypovolemic shock, that's fairly easy. You see, every other shock, if you look at that, the peripheral resistance is up. SVR is up. You see that? Cardiac output will be low when there is low volume. So hypovolemic shock, cardiac output is low because there is low volume. Cardiogenic shock is cardiac output is low because it can't pump. Obstructive shock, the cardiac output is low because there's no preload coming in. Okay? CVP on obstructive shock is high because it's kind of obstructed, so it's kind of jammed back. There's a traffic jam. On the hypovolemic shock, it's going to hypovolemic shock, the CVP is low. Okay, so basically when there's low fluid state, the cardiac output CVP will be low, total peripheral resistance will be high, except in septic shock where the total peripheral resistance will be low. All right, you can have it. So don't worry to memorize this. You'll know as you do it. Now, those measurements required pulmonary artery catheterization in the past, invasive procedure, and a lot of doctors used to do that at bedside. And these days, we try to stay away from invasive procedure if we could. And the way to measure that is through this new new device called Neupane. Okay, the principle they use in this is called bioreactance. What that means is, like you see, there are 4 sensors. Each sensor has the red one, the outer lead, and an inner lead. Okay, so outer sensors or outer leads are fed alternating current. So it passes through the body, and then the inner leads collect the data when it reflects back. Okay, and that's through mathematical algorithm made into numbers, graphs, etc. Now what it does, the way it looks at cardiac output and stroke volume and those kind of things is through a principle of phase shift. What that means is when the alternating current is going, because it gets into the heart, it bounces with the heart, which is pumping like that, and the current which is flowing in a way like that, it gets bounced off by the pumping action of the heart, and when it returns, instead of that phase, it's on a different phase because it got thrown off, okay? And that's called the phase shift. So basically coming in, it gets bounced a little more, and then there's a shift when you kind of collect the data back. And that phase shift gives you an idea of how much the heart is pumping. Okay, so that's the principle here. Now, talking about a shock state, and for you guys to understand whether or not this guy needs volume. Okay, now septic shock usually, as you saw, they are relatively volume deficient, meaning although they may not have bled anywhere or they didn't lose any fluid because of the tone, their peripheral vascular resistance is low, hence the preload is low, and they look like they need fluid. Okay, and how do you determine if somebody needs fluid? Is to know whether or not they are fluid responsive. And there are 2 ways of doing it, non-invasively. And one of them is the straight passive leg raise test. Okay, you have to do the leg raise in 45 degree, and you can only do these in people who are kind of doing okay, relatively okay, not like all over the place, kind of trying to jump out of bed, that kind of stuff. They got to be calm and relatively stable. Okay, and you kind of tilt them over, and then you take the measurements, and then you get them back to their original place and take the measurements. So before, during, and after, and you determine what really is going on. Okay, and that's how you determine whether they are volume responsive or not. Now, the numbers to look at when you put the Neupane on first is twofold. One, yes, you're going to find out whether they are fluid responsive or not, but even before that, if you collect some of the numbers, it will give you an idea of what kind of shock you're looking into. Okay, so what the numbers you need include stroke volume. Stroke volume, you understand what that is. For the same reason, stroke volume index. Okay. Next, you need cardiac output, which is kind of similar to stroke volume, and the cardiac index. Then you need the total peripheral resistance for the reasons we described, because if it's sepsis, cardiogenic shock, what it is. So you need the total peripheral resistance, and then it doesn't give the CVP, right? Doesn't give the CVP, and then you could also get that stroke volume variation. Okay,
and
so
change in SBI to tell the fluid response.
Yeah. So even before you do the fluid responsiveness deal, you get the basic numbers. The basic numbers include stroke volume, cardiac output, and stroke volume index and cardiac output, cardiac index, total peripheral resistance, and the stroke volume variation. Okay, so that's the basic number that you want to call the doctor with. The doctor should have some sort of idea of what he's dealing with to begin with. Because they say, in real medicine, 80% of diagnoses you make the history and physical exam. So when you listen, you should already have an idea this guy got this kind of shock. Okay, somebody with 80 years old, he had had triple bypass, he's not doing well, he's non-compliant with medications, came in hypotensive, he's swollen. Well, sounds like cardiogenic shock, right? You should have an idea. Somebody who's otherwise well, a young guy, does the IV drugs, he's very hypertensive, found down, gets septic shock, right?
So, NICOM is basically to confirm shock, or or you just assume they're in shock when you put them on the NICOM, and this is just to confirm whether they're going to respond to fluid or not?
Yeah, well, both. So, to confirm whether they are in shock or not, the definition, as we went through earlier on, you're gonna get to that definition even before you put the NICOM. Okay, so when you get to severe sepsis, even before they get into shock, if they're in shock, it's all set. But you still need the NICOM to understand, if you already don't know, what type of shock. And if somebody's in shock, well, they need fluid, that's really no biggie, right? So that's all goes there. The NICOM, the way we're going to use it is before they get into that shock phase. And to answer your question, you can determine at that time whether they are in shock or they are hypotensive only. And then you determine whether they are fluid responsive before they get into shock phase. So when they are in shock, NICOM is used to determine what type of shock. When they are not in shock yet, the NICOM is used to determine whether they need fluid or not. Okay, so that's that. And now once you call the doc with that number, then you get that NICOM going, and you, before and after, you measure the cardiac output, cardiac index, stroke volume index. Okay, and the TPR, SPR, if the NICOM gives you, then you do the stroke volume variation too. Any of those numbers, more than 10% variation, means they are fluid responsive. Okay, what that basically means is you raise their leg, and the peripheral heart of the pool dumped a lot of blood into the central circulation, and that led to increase in the cardiac output. You remember the Frank Starling's law? What happened was, the heart was pumping that much. You give fluid, well, it's pumping that much. And if the myocardium is normal, well, it's going to respond by increasing stroke volume. That way, if you dump more fluid, you're going to get positive effect. So meaning they need fluid. Imagine the same guy, looks like it's in shock, cardiogenic shock, however. Okay, you dump more fluid, guess what? The stroke volume might actually go down. Fluid you don't want, maybe they need diuresis. So stroke volume, cardiac output, their respective indices will tell you whether or not by dumping fluid or by feeding fluid, by getting fluid into the central circulation, whether their cardiac output will increase or not. Okay, so there's several levels. This gives you an idea of several levels. One is whether they need fluid or not. It also gives you an idea of whether what type of shock you might be dealing with. Because if it's cardiogenic shock, they are not going to be fluid responsive. So that's that. The same way you can do with the NICOM, you get those numbers up front, help determine what type of shock, and then now the fluid responsiveness part of NICOM deals with before and after cardiac output, stroke volume, cardiac index and stroke volume index, and stroke volume variation if available. And that's after you dump about 250 cc's or 5 ml per kg fluid challenge. Now the fluid bolus has to be immediate, max 999, boom, within 5 minutes or sooner. Because if you let it be, it kind of sips out and it really doesn't work. Okay? One time it was done over 2 hours. And it was determined to be not fluid responsive. And I went and I was like, when was that fluid given? Or before transfer? That was a long time ago. So it doesn't work. You got to immediately. That's why the leg raise, immediate. Within a minute you check that. Fluid, immediately you got to do so that it gets into the effective circulation right away. So if you're going to squeeze it, that's how you got to do it, immediately. Now, more than 10% again is the same thing. Preferably, if you're low oxygen, if they're monitored, their BP or the MAP will also go up, and if they are fluid responsive. Okay. Now, the way the fluid responsiveness works with NICOM, just for you to understand, is the alternating current. You remember that phase shift? Now what happens is current coming, it's going out. The heart was pumping this much, and it bounces it off that much, okay? If the heart is pumping that much, it's going to bounce it off that much, so the phase shift is going to look bigger. And that's the technicality of that thing called bioreactance. That's what it is. If somebody asks you, how does it work? That's how it works. Okay? Now, if somebody already has a arterial line in place, then you can kind of get a sense of whether or not they are fluid responsive by looking at what you call the pulse pressure variation. Okay, so the pulse pressure is systolic minus diastolic pressure, blood pressure. That's called the pulse pressure variation. If you have a lot of pulse pressure variation during respiration, it's going back to the same principle of the respiratory variation in stroke volume, okay, depending upon the preload. So this is going back to the respiratory variation. Now, if somebody's got an arterial line and you look at their waveform, and there's a lot of respiratory variation. So this is inspiration, inspiration, higher ones, expiration, expiration, inspiration, inspiration, expiration, okay? So if you see a lot of variation, more than 10%, then that means that that patient might be fluid depleted, and they might be fluid responsive. This is if they already have that stuff, okay? We don't put in many arterial lines these days, but if they already have it, that's how it is. But you don't have to put an arterial line to determine that anymore because of this wonderful machine, okay? Now, having said that, common sense never, nothing outweighs or nothing, what's that word? Nothing overrides common sense, okay? Because it's not going to be straightforward. That's why I was saying job of doctor and nurses cannot be taken over by computers. So at least in my lifetime, I got job security. Okay? So do you guys. Now this is just to kind of put it all together in a Frank Starling's curve. Remember that? So this patient is fluid responsive, meaning as you stretch or give more fluid, cardiac output is going to go up. So they are probably in that phase of the cycle, of the Starling's curve. And if you take them up much, then they're not going to respond as much anymore. And they probably are at that phase of Frank Starling's curve. Okay? So that's preload, afterload, preload and contractility deal. Now, management of sepsis, this is basically to resuscitate them, okay? Understand what is going on, find the source, control the source, resuscitate, and try to restore all organ function in a vague term. So that's how it is. Don't worry about this. I'm going to skip this slide, okay? And that slide. Now this is, I got this from Surviving Sepsis Campaign website. This is one hospital's protocol that they have in their website. And this is pretty much sums up what we discussed so far and what is the role of a nurse and the physician at different phases of sepsis. Okay, so if they got sepsis, what you do is that you stay alert, you get most of the lab works, make sure they got IV access, make sure they got oxygen going, and then you kind of find out, think what the source might be now that you've determined that this guy got sepsis. So try to find out the source. Maybe they need an x-ray for looking for pneumonia, maybe they need urine analysis to look for urine source, maybe they need a CAT scan of the abdomen, something like that. To try to find the source, make sure they got IV, make sure their oxygenation is good, and get all those lab work. Because that lab work is what...
Shannon McIver, please call the operator. Shannon McIver, please call the operator.
Because that lab work is what determines whether they have severe sepsis or not. Okay? Now if the lab works come back and they have severe sepsis, then you got to do that fluid responsiveness deal. Okay, whether they are fluid responsive or not. And then depending on what that is, you got to make appropriate phone calls, maybe try to transfer the patient to a step-down unit. Maybe the doc needs to come evaluate the patient right away. Maybe they need a different line, whatever. Okay, so that's what happens there. And if you determine they are fluid responsive, you give them a little fluid, they respond, everything good, that's fine. If they don't, then you know it's septic shock. Then obviously they got to go to ICU. They may need, if they're bad, they may need an intubation. They may need central lines placed, more fluid, etc., etc. So that's where it's at. And we have a similar deal here in Memorial Hospital. And this is the sepsis project. Folks came up with this flow sheet. And this flow sheet says pretty much the same thing in a different color scheme, okay? Now, up front is the screening criteria for sepsis. It's put in very simple, a couple of things that you will know on every patient anytime. Temperature, pulse, respiratory rate, mental status, and then whether if they already have labs, whether the labs look abnormal. So that determines whether they have sepsis or not. If you think they have sepsis, then you go to B, and you ask the question, wow, that was SIRS, sorry. Okay, so the first part is SIRS. And if you determine that somebody is screened positive for SIRS, then you ask the question, do they have infection? Is it possible that they have some infection going on? If you say yes, then it is sepsis, right? When you have sepsis, you determine, you get those lab work done right away, because that is what determines whether they have only sepsis or whether they have severe sepsis. And when the labs come back, and those are the labs there in that little box, when the labs come back, you determine whether they have severe sepsis or not. And at that time, you try to see whether they need volume, because they can go into septic shock. So you do that fluid responsiveness deal, and then you give them fluid or whatever, and then maybe try to move him, or whatever you need to do. You let the doctor know. And on this one, there's a little glitch in this flow sheet, because the Nikon gets kicked in as soon as somebody screens positive for sepsis. That's not the case. The Nikon should kick in when they screen positive for severe sepsis. Okay, so we're in the process of fixing that. We'll see. I know it has been a problem, right? In the nurses, those numbers, I mean, everybody getting those numbers, and it's labor intense. That's not what the guidelines says, and that's not what is done. So we're in the process of fixing that. Now, just the basic, the summary to define the nurse's role is early recognition, and that was the whole point about this Surviving Sepsis campaign, because a lot of the times they go through a phase of about 6 hours where they are okay before they crash. And the point is to find out whether we're dealing with something like sepsis, whether it's brewing up front, although the patients look normal at that time. And so the whole point is early recognition, and then early initiation of therapies to prevent them from crashing, and then for swift deposition of care wherever they need to go. Okay, so depending upon what you're doing, whether you have 1 patient or 5 patients, even if it is only severe sepsis and they are not hypotensive or anything, you may want to transfer them someplace, or however that works. So it's early recognition, early acting on the situation. So that's about it. Okay. All right.
Thank you.
Questions? I think what I wanted to say was like the NICOM. Everybody's doing NICOM. You may not understand why do we need to do this and stuff. So I mean, I hope this explains and you understand what the rationale is and why it is important. And when you do fluids and stuff, you understand what kind of hemodynamic situation we're dealing with. That was the main point of this lecture. Sorry, you were going to ask me something? You sure? I didn't mean to interrupt.
No, you're good.
Charlene, any questions?
No, I'm good.
Krista? No? All right. Good deal. Awesome. Okay.
Thank you.
Thank you.
For those of you who need to stay for the night, we'll get that